The first trimester screening. Good evening, everyone from Szczecin. I show you where is this city, but after a couple of words of the short summary. If you all we know, in 2009, Professor Nikolai Destim and Liona Punt presented in hypertension algorithm consists these four factors: maternal factors, ultrasound in uterine arteries, mean arterial pressure, and biochemical markers, PAPE or PAGF, with really high prediction value. But definitely, every change, the totally changed approach after the publication ASPRE trial results 2017, and 1 year before in Lancet, overview on preeclampsia, and look at this table. Effectiveness prophylaxis with the aspirin was close to zero. That's what's changed. Definitely changed the dose. Up to the 2017, we recommended 75 milligrams. From the ASPRE trial results, definitely changed, and we have a double 150. And according to this trial, we have this from the website from the Fetal Medicine Foundation. After the screening, two group: low risk, if we have the cutoff 1 in 100, and high risk if this risk is higher. So another one name which is very important. So people old like me or older remember triple test. Piotr mentioned about it, biochemical markers to screening the trisomy 21. But now we should know there exists new name, new triple test, which consists of uterine artery, PI, mean arterial pressure, and PLGF. This is a new triple test, very often used in the manuscripts, this name. And of course, after this manuscripts, after this publication, many societies publish guidelines, FMF, FIGO, ISUOC, and I would like to concentrate on the Polish country. Our society in 2019 presented, together with three societies, cardiologists, obstetricians, and the hypertensiology, management and recommendation about the treatment hypertension in pregnancy. And in this first recommendation was included that this algorithm consists four factors should be used in the screening. And after this screening, we should consider the prophylaxis with aspirin, but cutoff was limited to 1 in 150. 1 year later, in our country, we slightly changed approach. This our society, obstetrician and gynecologists, created new guidelines according to the ultrasound in prenatal diagnostic. And here, there are some different voices, and that's why we present slightly different approach, and it is included to our guideline. To approach, this means that we have two cutoff, 1 in 100, and second approach also acceptable in our country, 1 in 150. And of course, the next step is very clear. 150 milligram aspirin is recommended after the assessment. It continues until 36 weeks of pregnancy. But this cutoff is very important, and I show you in the next slides on my lecture. That's our activity as a society directed to the professionals, to the physicians. There we make the huge impact in this field of the science, and would like to widespread in the whole population of the gynecologists. But we also know that very important is rising the awareness and education of the pregnant woman, population pregnant woman. That's why we created the platform where we spread the education material. And I would like to show one of this material, which was prepared especially for the World Preeclampsia Day last year. And this is a new version of this movie, the short movie. I hope so you'll be patient and they watch this movie. 2 minutes with our opinion leader, new version with the subtitles. So look at this movie.
dzisiejszych możemy z dużą dokładnością prowadzić badania, które pozwolą na wyodrębnienie grupy ryzyka.
Nasze drogie pacjenty, preeklamsja to bardzo trudne słowo, ale zapytajcie wasze mamy lub babcie o zatrucie ciała. Prawie to samo. One bardzo bały się konsekwencji tego powikłania.
Gdyby w Polsce wszystkie stosowały profilaktykę rocznie 8 000 dzieci nie urodziłoby się jako choć mamy nie rozwinęłyby preeklamsji.
Zdrowia matki, profilaktyka opiera się na stosowaniu 150 mg kwasu pacjentów, który włączamy przed wszystkim i kontynuujemy aż do końca.
Hello everyone, I'm Liam from Hong Kong. Today is World Preeclampsia Day. What are you waiting for? Let's get going with screening and preventing early onset preeclampsia.
So, as you see, we invited the majority of opinion leaders and created a short movie together with Liona Poole. The prenatal project was the author of this short movie. So let's start. I show you my team and the experience in the preeclampsia field and the science in this field. So definitely in this moment, I would like to say thank you all the team, staff, professionals, high educated from the Department of Obstetrics and Gynecology in Szczecin. Look at this map. Szczecin is the university city close to the Baltic Sea between the Warsaw and Berlin. And I would like to show the young people who are really strong, engaged, and involved in this field activity, education, and also following the research. The Magdalena, Sylvia, Hania, and Piotr, they are the authors of these results. So I show you to present our first results. Between the 2019 and 2021, we included over 1,800 women in the preeclampsia clinic. In Poland, some of the pregnant women have routine trisomy screening. And thanks to our efforts, we include also mean arterial pressure, uterine artery in ultrasound, and fortunately the PLGF in this number of the patient. And this is the first results of our screening. The characteristic group, as you see, over 600 nullipars, over 1,200 multipars, some of the chronic diseases, and different cutoffs and different algorithms. Look at this, the algorithms with cutoff 1 in 100 for the preeclampsia. In this cohort, over 160 patients presented high-risk group. That's close to 7%. If we compare to the only PLGF, the same number of the people presented was going to the high-risk group. If we make the cutoff in this group lower, this cutoff 1 in 150, close to 10%, independent of the algorithm, or we use just only PLGF, of Papay PLGF was go to the high-risk group. Of course, exists also the qualification and the screening to the FGR, fetal growth restriction. And in this case, the number of the cases which go to the high-risk group in our cohort was to close 12% independent of two algorithms, or PAPE PLGF or only PLGF. And if we make the cutoff on the 150, the number high-risk group is close to 80% independent of the algorithm. Much worse is if we evaluate together P and preeclampsia in FGR, independent of the cutoff, 1 in 100 and 1 in 150. For me personally, it is not acceptable to so high rate people go to the high risk group, independent of the complication, because there are probably few will be observed if they take the aspirin, but compliance will be dramatically decreased if 1 in 5 women get the indication to get prophylaxis. And that's why we should very limited number of the women who get aspirin to increase the effectiveness this screening. That's why in my center, we recommend the prophylaxis with aspirin after the first trimester screening only if we have the algorithm with PLGF and preeclampsia risk is higher than 1 in 100. So it's a general results. And now I start present the conclusion, our first publication from this cohort. We compare different algorithms, PLGF, PAPE, PLGF, PAPE only, or without biochemical markers. I'm really appreciate the lecture of Professor Nikolai. I didn't know the subject, but definitely I guess that I should talk exactly about this problem. So look at this. This is just partially material cut off 100. The material was evaluated on first 800 people, and independent of the algorithm, number of the cases is the same. Let's look. Here's with algorithm with PLGF is 58, together is 60. Only with PAPE is 59. Similar situation looks if we have different cutoff, but if we compare patient by patient, of course, we don't see differences between PLGF and PLGF plus PAPE, and it confirmed Professor Nicolaides' team results. But definitely, and also it was shown today, there are differences if we use PLGF or we use only PAPE. Differences is close to 27%. This means we give the prophylaxis with aspirin different people. And this is very important. We think when we make the right screening, but 27% get the prophylaxis, and we are not sure that's the right group of the high risk group. And the same situation was if we make the cutoff on the level 1 in 150. The differences between the PLGF and PAPE was really high, close to 1 in 3rd patient. Another one, our observation for our results, the deviation, and Professor mentioned about it, between the PLGF and PAPE in our cohort. We observe the spreading of the results, if we use the PLGF, is much more narrowed if we compare to PAPE. PAPE has the wide spreading of the results, and probably it could be the also reason the potentially false positive results. And this situation is observed in our group, not only in 11, but also in 12, and also in 13 weeks of the pregnancy. Deviation of the median is totally different between these two biomarkers. And this is our first results from the first trimester screening. I would like just only mention that we have the experience also, and this long time before the ASPR trial results with the angiogenesis markers. And this is our experience in publishing with using the SLIT and PLGF. And I would like to underline these two ladies now collaborate with Professor Daniel Rolnik from Melbourne. We sent our database over the 1,200 cases with split and PLGF ratio. I hope so. We get the final summary up to the end this year. And it will be very satisfied results because it's a large group, maybe so large like present Professor Nicolas. I'm really jealous if I look on this number of the cases. So this was the presence, and that's the Polish future, I hope so. Many words what we told about the reimbursement. And this year, definitely we are closing the final details, but we start the first multi-center prospective randomized trial. I hope we include over the 10,000 women, and we are going to compare two arms between the pay and PLGF. And main goals of this study, which is named Placenta PL, that's of course the perinatal outcome, but also aspirin resistance. What is true, because we think there's much more less resistance when we think primary. And I think so the most important issue in this field is the patient compliance. And of course, additional the trophoblastin response to the aspirin. So in this short summary, that's our experience and Polish engagement in this field, very important field for maternal fetal medicine. Thank you for your attention and greeting from Stettin. It's a pleasure today be here and show our results. Thank you.